more attendees arriving, and then we'll commence with the presentation. For attending today's Practice Manager Network meeting. Today's meeting will discuss managing occupational violence and aggression in the workplace. I'd just like to, first of all, acknowledge and pay my respects to the traditional custodians of the land that we all meet on today. I do pay my respects to their elders past, present and future. And I would also like to extend my respect and acknowledge any Aboriginal and Torres Strait Islanders that may be in attendance today. My name's Belinda. You can try and pronounce my surname if you want, but I don't expect it. I'm a Regional Services Officer here at Gippsland PHN, and I work predominantly in Wellington, East Gippsland Shire. Just a few housekeeping points for today to consider. You will notice that your microphones have all been muted. If you do have any questions, please utilise the chat function, and we will endeavour to get to those questions during the meeting. There will be opportunities throughout the presentation to answer some questions. Likewise, there will be an opportunity for anyone that wishes to stay around post the meeting. There will be another opportunity to answer questions, and then some time to network amongst yourselves. So if there are any questions, anything that you want to ask of either the presenters or ask at the end of each other, certainly feel free to do that. Once we're ready for the networking, I will unmute everyone and you can have a chat. Today's session's also been recorded, and we will be sending a link out following the meeting, so look out for that in your emails. Along with that, we'll also have an evaluation survey that will be posted out. Please respond to that in order to get your statement of attendance for today's session. So for those of you who are not aware of Gippsland PHN, there are a number of core functions that we do have, predominantly obviously health planning, commissioning services, practice support, system integrations. We do also have a training and events newsletter. There is online event registration as well. Monthly we have the link newsletter as well, and if you want to subscribe or obtain further information, please check our website at www.gphn.org.au. Now with our health planning functions, basically what we are utilising there, gathering data to determine any key priority areas within our region. Our commissioning services direct funding to various health priorities, so that normally is a result of that health planning, basically to service those underserviced groups. With our practice support, we do provide support, as many of you would know, in a number of different ways. So it may be from quality improvement activities within the practice. It could be supporting you with your digital platforms and supporting other health professionals as well. We also work with health professionals to create efficiencies and connect other health systems. Basically, that all helps improve the health outcomes and the coordination of care through efficiency and effective health systems. So we do have a digital health team here at Gippsland PHN, and our digital health team do provide us with a toolbox of technologies and techniques that help support innovative patient and caregiver model of care. They are aimed at improving patient engagement, increasing accessibility, improving the quality and safety, and enhancing efficiency and sustainability. Now, we can help you with your digital health with the use of Polar. Many of you may have already had that within your clinics. If you are interested in Polar and you don't currently have it, please reach out to your regional services team. Otherwise, you can contact us through our website or by emailing info@gphn.org.au. We also have support for My Health Record, support for the Gippsland Health Pathways as well, and the Digital Health Guide. Likewise, you can obtain further information on our website or through that info@gphn.org.au. There are a number of other emails that you could use or reach out to that regional services coordinator. So on to some statistics here for workers' compensation. We all know that it is a big factor of a lot of employees and employers, and there's certainly a lot of information out there in regards to it. But there are 17,190 serious claims by the healthcare and social assistance in Australia. That's across the 2016-2017 financial year. 16% of those claims came across all industries. However, social workers and nurses were amongst the most affected in that cohort. The cost to Australian economy is 61.8 billion, which is a huge cost to our economy, with 77% of all those work-related injuries and disease costs being borne by the workers themselves. So it is a massive expense. So workplace violence is fairly prevalent, unfortunately, within Australian workforce. Almost 20% of workers say they've experienced discomfort due to sexual humour. 22% of workers have reported being physically assaulted or threatened by patients or clients within the workforce. 37% of our workers have reported being sworn at or yelled at in the workforce, and 11% of our workers have experienced unfair treatment due to their gender. So mental health related disorders have been fairly high within workplaces as well, and they actually make up 6% of all claims in Australia. 21% of those claims are for healthcare and social assistance workers, which is a huge percentage of claims. Generally speaking, there's about 14.8 weeks off work that is taken due to mental health disorders, with a huge 90% of those disorders attributed to stress. You can see that nearly 2.5 times more claims are for females than are for males, and the compensation claims for mental disorders are lodged generally due to work-related mental stress, by underestimating the size of the problem, particularly in that lower socio-economic jobs and regions. So I'd just like to introduce our presenter for today, Tanya. I should have tried pronouncing your surname, Tanya. Apologies for not trying that. Tanya is from One Borough Consulting, and she has an extensive background in the health sector prior to establishing her consulting practice. Tanya has seen firsthand the impacts of minor to extreme occupational violence events, and during her time, and for the past 4 years, she's been supporting public health services to develop robust OVA prevention and management programs, as well as promoting a focus on the workplace wellbeing to mitigate the realities of modern day healthcare. So Tanya, I'll pass the mantle on to you. Thank you for attending.
Thank you. Yeah, we can have a competition about the most difficult surname, but I think you might still win that. So it's Heaney Voot for anyone that's interested. Before I share my slides, I might just also share that not only, I guess, from a workplace perspective, where my background is, and I cut my teeth in sort of divisions of general practice land. So my background way back is primary care. But from a personal perspective, you know, I have 3 children or 4 in high risk OVA professions. 3 of those are health, plus a daughter-in-law. So, you know, on the home front, I really see the personal impact of OVA as well, and get to hear some pretty interesting stories as the children and adults are debriefing. So I guess it gives me this really holistic picture of, you know, OVA and the impacts from a business perspective, as well as, you know, the human side. So let's just kick off, just share my screen. Okay. Thank you for those of you that have already gone and completed the first poll. I saw that there were a few responses there, so you've obviously sorted out poll EV. If you haven't, please don't fret. You can use the chat box if that's easier for you. What I like about this poll EV is that we get to see it all real time on the screen in front of us populating, and just makes these Zoom sessions a little bit more interactive and fun. And the other thing, I just wanted to kind of take a breath. You probably had really busy mornings. You've all scrambled to get here. There's a million things going on around you. And I just want to really get everybody to take a breath, feel your feet on the floor and just get present for this session. I don't know if you've done anything like that before, sessions before, but I actually find it really quite good to just ground us a little bit. These are the learning outcomes that we are really confident you're going to have after the 2 sessions. We really want you to obtain the sort of deeper understanding of the contributing factors of OVA and look at some of the intervention strategies that are really applicable for you in your practice. We want really to give you a lot of practical information, including a template for those that don't already have a comprehensive risk management system in place around OVA, or to maybe add some extra value to those of you that do. We're really going to look at the impact of OVA on your employee wellbeing and talk a lot about the impact that even minor OVA has, because often it's neglected, and we'll talk a lot about that. And I'm going to give you lots of great resources to help you continue your great work around OVA in your clinics, and we're also available to support you for any extra support you might need. So in terms of today, this is what we're going to look at. The first thing we're going to cover is, really, why is OVA so complex? Why doesn't just a sign up on the wall work? And I'm going to give you a bit of a roadmap, a visual roadmap that's going to help put all of this in perspective. Then we're going to examine the 7 OVA severity levels and the offender continuum. You may or may not have seen those graphics before. They come out of WorkSafe material, but I find them really quite handy to help us sort of break down that commonly used phrase OVA and get a bit more meaning under that. We're really going to examine the internal and external factors that contribute to OVA events, and that's not only from what we might call the OVA offender or perpetrator, but also from the staff response perspective, because again, there are a number of factors in OVA and we need to examine all of those. And we're going to look at your OVA system. So, look at your prevention, your management and follow-up systems. And I'll have a template for you next week that will help with that. All right, so I will stop for questions just as we go along every now and then, so feel free to unmute yourself and sing out when I do that. But firstly, why is OVA so complex? It's so complex and so hard to figure out how to approach it because it involves people. And, most of you are managers, so you'll know that people can be both delightful and both, really quite difficult. All sorts of different people that are coming into your practice and the people that you're working with in your practice. So when I talk about people, I'm talking about your staff as well as your patients, your clients, your customers. We're all made up of many different things. And each of us bring our own baggage, our own fears, our own personal history, and our own values and belief systems. And our values and belief systems can, create bias in some ways. So in some cases there's unconscious or conscious bias, and we can judge people just by looking at them. We make assumptions about who they are, how they're going to respond to us. Like I said, our personal history can affect us. This still goes both ways. Fears can affect us, and I'll examine this a little bit more deeply as we go and give you some scenarios. But it's not just someone walking into a clinic for an appointment, for example, with no previous history or baggage or concerns or worries or fears. All of this is playing out for people under the surface. So this is what I refer to as the intrinsic factors when I start talking about that. This is sort of our landing page, I guess, or our roadmap. Now, it does look a bit overwhelming initially, so if you bear with me. What we're going to talk about over these two sessions is, systems and people, because OVA requires this sort of holistic approach where we're looking at all of our systems and then really understanding the personal factors, staff and OVA, the perpetrator, offender. I'm going to interchange those terms all the time. So if we look at this from a systems view, what we see across the top is obviously as an employer, there are legislative requirements to keep your workplace safe, your workplace safe, your people safe. There's common law duty of care. You have a psychological safety. You need to make sure everybody's psychologically safe. So you've got these legislative requirements. There's a bit of colour coding going on here, okay? Red is something you can't control or influence. It's just there and you need to work with it. So our legislation is pretty much just in place. You might be able to influence it if you want to respond to draft acts or something like that, but generally it's there. There's no control over it. You've just got to comply. And then we've got things within our practice that we can control. So this is the blue. We have full control over anything in blue. We have full control. So if we think about things from our external practice environment, I would imagine the majority of you have got some OHS site audits in place and checklists. You've looked at things around physical safety, so lighting, external lighting, leaving in pairs, all those sort of systems that you have to keep people safe coming to and from work if it's in the dark, remote, etc. And then there's the internal practice environment. So these are the systems we might have in place internally. It might also be around how we've designed the practice, and RACGP, they used to have a book on exactly that, practice design. It might be your systems for responding. So, you know, what sort of response teams do you have, if in fact you have something around this? What training is provided to staff in how to manage an event to de-escalate, but how to seek safety. So these are all our internal systems that you have full control over. Awareness, you know, you're doing that by attending this session, which is great. The signage is one part of many different things you need in your OHS system, and screens, which we're seeing a lot more of now, which is great. And then our post-incident response, which can be a bit of a gap as well. So what happens after there's been an event, and it doesn't have to be a really physically aggressive event. What happens after? How are we following up? How are we providing support? How are we flagging those patients in the file so we know and we can keep an eye on their history? Was it a one-off, or is this a pattern of behaviour? We're going to examine that a little bit more, what you can do about that. So all of this is what the good news is you have full control over, okay? Maybe not the design of your practice if you've inherited that design. Then we go over this side, we've got our perpetrator potential or known. The red is because you can't control the way people behave. None of us can actually control another human being. The green is influence. So up here is your little code. You may be able to influence that. So with the systems and with the behaviours of your people, you may be able to influence OVA events. You may be able to prevent some, you may be able to de-escalate some, and you may be able to stop some from becoming more severe. All right. But I guess let's just get it out now. Nothing you do will stop it completely because you can't predict human behaviour and you can't control the behaviour of others, but you can minimise some of this and help manage it better. So I'm sorry for those that came on here to get the silver bullet. There isn't one. There's a lot of things that you can do. So over here, we've got the intrinsic factors again. So this is your staff. So that those internal intrinsic factors around how your staff might respond to somebody who's, whose tone is a little curt, who's perhaps getting a little grumpy and frustrated, and also, how they respond emotionally. What's the impact on their well-being if someone's abused them? So you can see why it's complex, and you can see why just a sign on the wall isn't going to solve all of the problems and isn't going to cure all ills around OVA. And so the subject of our two sessions is really encapsulated by this little box below. We're going to be looking at all of the systems. We're going to look at the culture of care. So that's, we're going to examine how we're supporting our staff to deal with the realities of OVA and the fact we can't control people, and it's tough, makes their job tougher. And these things together will help you create, a really positive workplace and a focus on workplace wellbeing. So bear with me as we move through. I link in some of these squares or rectangles, and we'll look at the colour coding again, because what I'm trying to give you today is a sense of what you can do, where you can put your energies that will make some differences. because often we kind of fight the red, we fight the things we can't control. So let's have a look. Up here you'll see I've got people and systems as we go through, so you know which angle we're kind of looking at. And then you'll have either the sort of staff, internal side, or you'll have the offender side popped up here. Hopefully this is all making sense so far. So when we talk about OBA, you know, I think if you were to talk to somebody about OBA in the community that's not a health worker, they immediately think of some of the images we've seen on the news or throughout media campaigns of someone getting a punch. You know, and most of us get that. We get that that's really unacceptable behaviour. We get those extreme acts of violence. And, you know, we tend to know we need to respond pretty proactively when something like that has happened. And our response tends to be commensurate with what we perceive the severity of the incident to be. And the problem with that is how we've perceived it based on all of our intrinsic factors may not be how the other staff member has perceived it. And I'll explain this a little bit further. And what we do know from the evidence is that, you know, there is a cumulative effect of even minor OVA. So if you've got someone on the front desk who's just copying, you know, a fair bit of grumpiness and pushback and just difficulty each day, even though it's not really what might be termed a serious OVA event, that can have a cumulative impact on that person's emotional well-being and mental health. And so this is really, you know, this is the evidence that we really need to take into consideration, particularly in general practice. And the other thing I just wanted to highlight is that, you know, this fight or flight instinct, we're all trained, you know, we have this evolutionary instinct to either fight or flight from a risk or a threat. And it goes against our natural order of things to have to stand there potentially and deal with someone who's difficult, to not respond and react and fight back, which might be our overwhelming intention and we want to, when you can't run away. So, you know, there's sort of impact of this on us emotionally too. We're kind of stuck, and this is where we'll feel we don't have much control. So the OVA severity spectrum, there's a reference down there, which is a WorkSafe document. Page 73 has this graphic on it, but it also has a risk control matrix based on these. So if you want, I don't know how many of you are familiar with sort of the risk control framework. I'm happy to have a side discussion at the end of the session or follow up. There's just a caution in that WorkSafe guideline, though it will get you to assess risk based on these. My caution would be, don't assume if you come out of low risk, don't assume you don't have to do anything, you know, different or proactive, because the focus really for us over these two sessions is around your workplace wellbeing, your workplace culture, and the impact of minor OBA on your staff. So this is the severity spectrum, and we see these sort of minor verbal aggression, heated disagreement, grumpy patients not getting what they want, escalating up a little bit more to starting to swear, specific, non-specific threats. So they might be making some pretty nasty threats, but they're not directed at the actual individual that they're getting grumpy at. Then we can move up to this sort of threat intimidation. So specific threat to harm. So it's actually, I'm going to kill you, or if you don't give me this, I'm going to bash you, or whatever it might be. And they might be getting overtly physically aggressive. So this could be where they start banging furniture around, banging on reception desks, just quite intimidating gestures. You know, they're physically intimidating by the aggression coming out of their body. We've all, you know, I'm sure all of these we're very familiar with. And then we move up the line, obviously, to some really severe events where we're looking at attack with weapons and potentially death. And, you know, you'll know across health service in the state, we have had incidents where health professionals have been actually killed in their work. But across our region, we also have had health professionals who have been injured with weapons. So this is a reality. I hope dearly it's not been your reality, but this is a reality potentially. So this is, you know, again, when people talk OVA, it's one simple word, but this is a complexity that sits beneath it. And I think it's important to understand each of these levels and also understand that each of them has an impact on individuals. I'm just going to I'm going to talk about the language that I've used here, because if you've read that, and you'll know it's really politically incorrect language. And I'm just going to disclaim that this is sort of the terminology used in some of the more acute spaces that deal with OBA. It's a pretty quick way of determining, is this person, you know, do they have a cognitive impairment that's influencing their behaviour or a mental health issue, or are they actually just a bad person? Because they exist too, right? So you'll forgive the really poor terminology there, but it just cuts to the chase a little bit. And this is the range that we might see. So it's the concerned family member or patient, you know, who's frustrated, in pain, whatever it might be, to the mad or the bad. I would speculate that the majority of what you see in your practices sit in these three. That would be the most common. Now, there may be incidents where there have been more serious events. So I'm going to ask you to tell me that for sure in a moment, but I speculate that's where most of you will sit. Again, I just want to keep reinforcing, and you'll get sick of me, but I want to reinforce it because, you know, this is pretty heavy going. Doesn't mean this doesn't have an impact. This is very important to still deal with. So I'm going to activate this poll. I'm going to move all the faces so I can get to it. Some of you have already filled this in. Oh, hang on a minute. What's going on? Oh, yeah, no, very good. So, can everybody see that poll coming up as live now? Feel free to pop in the chat box or unmute yourself and yell at me if it's not coming up as live. Sometimes it can be, there we go. And this can mess with your head a little bit because you're watching it and thinking, oh, everyone's completed it and it's 100%, but as others fill it in, the graph starts to change in front of you. I'll give you a couple more seconds. Okay, I mean, it's not surprising. I would have thought there might be a couple who had some pretty, oh, there we go. Yeah. Ooh. Okay, has everybody had a chance to do the poll? So, see what I mean by it messes with your head? It's very interesting how it does that. So we're going to assume the majority are in the sort of minor to more severe forms of verbal aggression. Now, again, like I've said, the difficulty with this is that there is a perception that it's not you know, a big deal. It's not a major event as such. Staff are much less likely to report the incident, and staff are much less likely to seek help. And, you know, I spoke about the cumulative impact. So it might be a relatively low level of severity, but if it's happening every day or several times a day, this has an impact. We're not really born or trained to take abuse day in, day out, and that's the reality of what many of you face. So your staff may not come and put their hand up to you and say, look, I'm actually not coping very well at the desk because, you know, I've copped a bunch of really difficult people. They might fear appearing weak. They might fear an impact on their job because they might think, well, this is just part of the job, and if I'm struggling, you know, the practice manager might think I'm not cut out for it. I may not get extra shifts, whatever it might be. You know, we tend to compare a lot. Oh, well, you know, Jenny, she's had as many issues as me and she's fine, so it's just me, I'm not resilient enough. So there's all this stuff that's playing out for people, and they're not really understanding the validity of their feelings. So we need to overcome that. And you can do that by simply putting out the message around that severity level and the message around the cumulative impact and that it's real and those feelings can be valid. And you can also do it by making sure you ask. So whilst you might have heard there was a bit of kerfuffle at the desk potentially, or there was a bit more than a kerfuffle, we tend to ask straight away, are you okay? And we might get, yep, I'm fine. And then it's forgotten because we sort of think, okay, that's good. She's fine. It's dealt with, or he's fine. And I think it's really important to ask a few days later and to perhaps do that privately. So bring them into your office and just say, look, I just want to check in and make sure you're feeling okay. That I know that was a difficult situation, or, I know we've had a lot of these situations lately. I just want to check in with you and how you're feeling. Just asking the questions is really helpful. Again, everyone has these different internal factors, intrinsic factors that impact how they respond to these events. So what one person does won't be the same as what another person does, and it's understanding those individual differences and having compassion for all of them. So let's look at the types of offenders that we see. Again, this is a WorkSafe graphic, and they've done a study and some research. There's 5 main offender types that are perpetrating OVA. It sounds all very criminal, doesn't it? What we've got is this graphic that shows health workers' tolerance of those types as such. Now, generally, we understand someone's behaviour may be impacted by sort of a cognitive decline, dementia, Alzheimer's. And so we're much more likely to accept OVA from these people. It doesn't mean we like it or tolerate it, or should, but we tend to accept it a bit more. Again, because this is a research study of health workers, we see mental health is also, we understand that it's not necessarily the patient's not in control of their actions. If we did that in the community, this would probably be quite different, this study. Drugs and alcohol is sort of in the middle, and this surprised me too when I first saw this. I thought that would probably be on the higher end of intolerance. Person under stress, so we're waiting too long, we're in pain, we're worried. To the person who uses aggressive behaviour to get what they want. They know the system, they're a pain in the backside, they know how to get action. They're the ones that we're really irritated by. So these are sort of, I like this because it gives you, again, breaks them into sort of categories, I suppose, that you can focus activities on, because what the research also showed is this is the group that we have the most ability to influence. So, we talk about influence and control. This is the group that we can influence the most by some of the intervention techniques that we might use. So, there are things that we can do. These ones, let's face it, we really probably just want to bop them on the nose themselves. They're always going to be the ones that just know the system. So now I want you to go back to that trusty poll, and I want to know what are the most common types of offenders you're seeing. And I've sort of changed the wording. Take a moment to read through those descriptors. Sort of patient or carer frustrated, in pain, waiting times, they're concerned for a loved one. They're under the influence of drugs and alcohol, the mental illness or cognitive or sensory impairment, and that person using the aggression to get what they want, or other. If you've got a combination, just click other as well. If anyone's having issues with the poll, just come off mute and sing out, okay?
It's not live yet, Tanya.
Sorry, what's it doing?
I can't, it's waiting for you to bring in it.
Okay, you just activate again and we'll see how we go.
That's better.
Is that better?
Yes, thank you.
Wasn't holding my mouth the right way. Thank you. Wow. when we send the slides out to you, I capture the final results and I put that in the results slide in, so you'll actually have what the final results were on each of these quizzes in your slide deck as well. Okay, so would anyone like to share, those of you that have answered other, it'd be great just to hear from a couple of people whether that is something other than that, or it was the combination issue that you see, some of all of the above. Please feel free to come off mute and share.
Yeah, ours is a bit of I went other because it's more of a mix. Probably mostly A and B.
Yeah.
And a little bit of D.
D are the pains, aren't they?
Yeah.
Well, I mean, let's just cut to the chase. They are. Yeah. Okay. Thank you. Does anybody else want to share? Any others that said E? Was it a combination of all of these, or was there something else other than those 4 categories? No? Okay. Let's kick on. So we're going to look at now these sort of internal and external factors that, yeah, I mean, we go back. The good thing, if there is a good thing, you know, we've got this category, what we know from this is that this is the one we can influence the most, okay? So when we talk about our control, our influence, you know, putting energy into this means we'll get a better result, I guess. So let's look at how we might do that. So again, let's look at all the internal and external factors. So remember the internal, the intrinsic, our own baggage, our own fears, our biases. And then the external factors we'll also look at is around what's going on in the environment around us when we're in this space, the clinic. Now, again, this applies for both the patients and your staff. So externally, the environmental factors, we've obviously got the noise or different sounds. Anyone else dental phobic? I'm not too happy if I hear the sound of a dental drill. So, you know, noise and sounds can be a big issue for people, particularly with sensory issues. Lighting, same. Effective communication is a big trigger for a lot of people, and at the moment, this has been exacerbated all round. It must be driving you all mad as much as it is the patients, because the masks bring a whole new level of complication to effective communication. And we're sort of losing our body language too. We're losing the softening that we can give, or the reassurance we can give for somebody with a smile, but also it's very difficult to hear. So people that already had hearing impairments, big problem here. And, you know, we tend to be pretty bad when we're actually talking to people. We tend to have our heads down, we're writing or we're logging details into the computer. So we're already not great at that kind of direct face-to-face contact. If you pop a mask on that, it's just got extra complicated. I don't need to tell any of you about that. Pain, obviously, fear and worry, these are pretty obvious. Needs not met, again, it's all sort of connected. These can be sort of your drug-seeking behaviour too. And then the green ones sort of relate to your internal staff, okay? There's the intrinsic factors that can play out. So how your staff are responding to all of this playing out for the patients who might be getting a bit restless. You know, a big factor can be around the perceived lack of acknowledgement or care or empathy from staff about the situation. So I'm sure you get this, the waiting times, yeah, whatever, you know, it's just the way it is. But there's ways that we can de-escalate these common issues just by the way we respond. And yeah, it takes a bit of extra energy for staff who have been dealing with the same complaint all day. I completely get that. So this is your tolerance, I suppose, tone and defensiveness, and the perception of preferential treatment, so others called in first. This is a big factor in EDs, obviously, because people are triaged according to acuity. In general practice, it might have people waiting for other doctors, and the other doctors are running on different times. Sometimes for people who really aren't in that great space, they'll see 3 people that have come in after them that have been seen before them, even if it's not their own doctor. So they can get a bit extra agitated. So these are all things playing out for people. Other people in the waiting room, you know, screaming children running around, all of these things. So I kind of call these sort of volatile emotional situations where we do have the potential sometimes to influence and diffuse. Yeah, okay, sorry, I reordered my slides earlier. I'm just double checking where I'm at. So poly again, we activate this time. You know, every time I'm about to talk about OVA, I seem to have an event where I end up frustrated in a healthcare setting. So, which was me last Thursday, slight back issue and ended up in ED. We've all been there. We've all been there with our family or been there for ourselves, and we've all felt that frustration and sometimes anger. And there can be a number of reasons why. So some of you are already getting onto this, thank you. It can definitely be the waiting times, frustration with waiting, the pain, people around you. It's a bit of a big trigger for me is a lack of empathy or care from people, and bless our triage nurses in the hospitals, but you know, I've had this conversation that it's a little hard to be very empathetic to every person because the reality is we're going to have to wait, but sometimes there can be a sense of, you know, do you get how much pain I'm in? Do you get how worried I am about my child who sprained their wrist? You know, we don't tend to, in that point, be rational about why we're waiting so long, for example. We just know we need our own needs met. So we all can understand and empathise with what goes on for our patients. We just, when we're in work mode, we're not really thinking about that. So 100% waiting times and frustration.
No, sorry, mine isn't activated. It was, and then it disappeared.
It's a bit of a nuisance, isn't it? Let's try again. There we go. Is that better?
Yes. It was there, and then it disappeared, and then it came back. So.
There we go. Yeah. Ooh, love it. Look at that. How even spread is that? The downside of this is I can't see when everybody's finished. So I can't see when I've got, you know, X number of responses. So we don't know whether to talk to the results or they're going to move in front of me again. Yeah, it's interesting. And the mixture is right. Because obviously if you're in pain, the waiting times is going to increase your frustration. So, you know, that all connects. But, you know, it's important that, and this is a nice activity to do for your teams as well, because we just need to understand sometimes what's sitting behind a lot of the behaviours that we'll be seeing. Not always. Sometimes you've got your bad people, but that group that we can influence the most, this is what's playing out, right? And you know how that feels. Okay. So let's go back to what you can control and what you might be able to influence in regard to these factors. Again, we're on the people. So I'll remind you about our colour code. The control is blue and the influence is green. All right, it's a busy screen. Let me just talk you through. Let's start from left. We'll go down the bottom here. So obviously you're neurodiverse, people with sensory conditions who are triggered by lighting and noise, or those with a cognitive impairment. You know, we can influence them a little by making sure we're looking at the light and the noise. You can't always control that, right? But sometimes you might be able to. And obviously the pace of communication will be very important. How we're looking directly at people, giving them a chance to respond, all the things we know about you know, communicating with people with cognitive impairments. I've circled these with green, the waiting times, the volatile emotional situations, because you may be able to influence them. You can't necessarily influence waiting times, but you can influence people's response to them. And most people just want to know how long, roughly. You would have all had this issue, and I'm sure you've got lots of strategies for managing that. It's just about the communication. So over onto the right, again, I've got noise and sounds in blue. So in terms of controlling, if you've got a patient who is a regular patient who has, you know, a sensory issue or a neuro issue or a cognitive impairment issue, and you know they're triggered by any of these things, then I guess there's some proactivity in setting up the appointment, I suppose. So if the waiting is really crazy and you've got a spare room, you know, is it about, do I just put that person in the other room to minimise the chance of them being triggered? So there's some things you can do for some patients if you know, and it's a situation that they can't control. It's not about bad behaviour. The influential parts is certainly around the effective communication, as we've spoken about, and as we've all felt, you know, a sense of empathy as well. Managing unconscious and conscious biases, And again, I'm really happy to have a side discussion with anyone who wants to explore that more, but it can be a big issue for a lot of people. Certain types, you know, drug and alcohol affected people, some of us can get quite intolerant about people that present with those sort of conditions, or they look like they're presenting with those conditions. So we have to check our biases. Pain, there's not much you can do about, but what you can do is try and reassure people and just empathise. So I understand you're in pain, and I know how challenging that can be. The doctor will be with you as soon as he can. You know, are you more comfortable laying down? Obviously, you would have all these strategies in place. These are standard things you would be dealing with every day. Fear and worry, needs not being met. It's just the reassurance. You know, it's green because you can't control it, but you can influence, I suppose, how they're feeling. At least they're feeling cared for. At least they're feeling like you do understand they're in a lot of pain, that they've been waiting a long time. And this gets tricky too, because, you know, but in general, you may be able to influence some of this. Now this in blue, is, again, it's interesting. I got it in blue and I was like, really needs to be green, but because we can't control how people behave, and your staff are people, and again, we all have our intrinsic factors at play, but you can control the expectations you have as a practice manager of behaviours of staff. You can control maybe some scripts you have for these common frustrations people experience in the clinic. So you can control the training that you provide for people and how to respond and how to address those things. So there's some things you maybe can do things about. And again, these expectations around how we expect staff to respond to people. Alex is going to talk a lot on the next session about how we manage our own, our own self-management when we're faced with a difficult situation and we're in the middle of sort of, or trying to de-escalate or prevent an OVA episode. She talked a lot about it because, again, we want to fight sometimes, because who are you? How dare you be speaking rudely to me? And there are days where you do want to just rip people's heads off. Really, that's without a doubt. But, I really like Alex's message, which is about, well, this is all about keeping you safe, as in us safe. So sometimes we've got to swallow that to keep ourselves safe. We'll talk about that. Yeah, so I think in summary, empathy, understanding and compassion really will help manage some of those volatile emotional situations. I just want to say here, I want to acknowledge that we're all human beings. Your staff are human beings as well. We suffer from fatigue. We suffer from poor night's sleep. We suffer from our own worries and our own hurts and pains. So sometimes it's really hard to come in there and just get rid of all of that and be the perfect person to respond perfectly to these challenges that might present. We get that. These are just some things that you can look at to improve your response. But we're not robots, right? So I'm going to start talking about systems, but before I do, has anyone got any burning questions that they want to raise now before I crack on? Just keeping an eye on the time. Speak now or forever hold your peace, all good? Great. Okay, so remember our purple up here, our people. Remember at the start, our landing page, that our OVA needs to be approached holistically. We need to look at the people and the systems. I'm really keen to hear from you what systems you have in place to prevent and manage the types of OVA events that we've been looking at. And we'll have 5 minutes or so to discuss this, but let's just define systems. So a system is, a standard way of doing something, how everybody knows they respond, for example. And it can be a policy, a procedure, it can be your risk. You've done a risk framework and you've put controls in place for various types of OVA risks. It can be guidelines, job sheets, flow charts, the scripts you've got at the front desk for your teams to manage the frustrated waiting, how your team responds if someone's under threat, what alerts. Would anybody like to share an example of, just one system that they might have in place? Great to hear from you all, just so I can make sure you're not all asleep there. Please feel free to take your camera off and put your camera on and unmute and share.
I think we have a shy bunch here, Tanya.
We're all still hoping someone else will go first. That's what it is. Does anyone have and if you know how to use your sort of Zoom tools, you can do a thumbs up in your screen, but does anyone have a script at the front desk for, you know, managing the frustrated waiting patient? So just sort of standard wording to use in response. So the risk when people don't have their cameras on to see is that you do feel like everybody's gone to sleep out there. Is everybody there? Is everybody still okay?
We have zero tolerance for aggression and violence. We have a sign. We have a sign to say that.
Yep. So
and
you have
if we're late, we apologize and explain why we're late, and tell them how long we're going to be, and offer them a drink or something, or water, or a nice place to relax.
Great. And is that written down? Is that in your policies? Your policies?
Yes. Yes, and a big sign at the front door as well as inside the waiting room.
Okay, great. Thank you. Thank you for sharing. If you were in the room, we would have given you some Smarties or something as a prize for being brave. All right. I'm going to give everybody just a little bio break, a 5-minute break. For a number of reasons, we just get sick of looking at the screen. So grab a drink, run to the bathroom, have a stretch. And in 5 minutes exactly, which takes us to about 1:57, we're going to come back and resume and really get into the systems side of things, okay? So, see you all in a moment. I don't know if I warned you we were going to take a little break, Belinda.
Yeah, I did see that in the slides originally.
People just need a minute, I think.
Good stretch.
I'm just going to have a little drink.
Go for it.
Of course, if we were in the room with you, Belinda, we would have champagne and macaroons, wouldn't we?
Of course we would. I don't know if we'd probably be able to get rid of get the champagne over the line, but definitely the macaroons and the cupcakes. I think that'd be a nice addition.
I think that's a lovely way of coping with OVA. Macaroons and champagne.
Yeah.
Yeah, that photo makes me hungry though.
I know, it's a naughty one. Sorry.
Teasing me.
Yes.
I've got part of it. Does a cup of tea count?
Yes, all right, fair enough.
Better than nothing.
It's a poor cousin, really.
Belinda, what's really in your cup of tea? What's in your cup?
It's Greek tea, I promise.
Is it?
Yeah, that's right. It could be anything.
Spike
That's
with it. It
exactly
could be
right.
Irish tea, really, couldn't it? You wouldn't know.
Yes.
I did that. I think I'd be on the floor right now.
Yeah, that's it. I'm definitely, you know, I'm just all talk because I would need a snooze for sure. Okay, where are we at? 1:57. Okay, let's start. So I hope you all enjoyed that little visualization. These are the things that we'll have when we can all celebrate getting back in the room together. Something to look forward to. Okay. So let's have a look, another kind of busy screen, but I just want to show you what we're going to cover today and in the next session, essentially. Sorry, I'm just moving all the heads so I can see my own screen. So this is when we're talking about, you know, our overarching system, where we need to be looking at a number of factors as well as the people. So this is the sort of holistic view. So we've got our systems, we're going to explore that in detail, and we've got the people side. We've talked about that a little bit, we're going to keep exploring that. And what we're going to look at now is the prevention side. In the next fortnight, our second session, this is where we're going to really go into all of this. And we're going to hear from Alex around these great practical early intervention and de-escalation strategies, how to manage, you know, I guess an acute OVA episode. And then I'll talk as well really about how we follow up and look after the wellbeing of our staff and really promote a positive, healthy workplace. So yes, we've got systems and people. That's what you take out of today. You've done well. So let's have a look. So remember I said I'd show you our little, these little rectangles again. Remembering red we can't control, blue we can control. I'm also giving you a bit of some links here to some useful documents you may or may not be aware of, okay? But so we've got our legislative requirements also spelled out a little bit here, okay? It's a busy screen, sorry. But essentially the sort of the external, the internal and the emotional safety. So emotional safety is also a legislative requirement now. Like we are required to provide a psychologically safe workplace for our employees, which gets very challenging when we've got these sort of high risk jobs as well. So Victoria is the OHS Act. I know your standards will talk about WHS, but Victoria, we still have the Occupational Health and Safety Act. If you want to go and research, by all means, I'd suggest you have some champagne before you go and do that. And then, you know, we also talk about, what they talk about in the WorkSafe sign and in the OHS Act is psychological hazard management. So what are the hazards to people's wellbeing, essentially? We all have a common law duty of care, and this is around negligence. So if we see something that may harm people and we don't do anything about it, we don't identify and we don't rectify the risk. So that can be a common law issue. And this sort of feeds down, all of this stuff has been fed down into templates you'll have doing your site audits and your OHS systems, what's become your OHS policies and your policy and procedure manual. And for your perspective, you know, those that are accredited and will follow the RACGP 5th edition standards, these are your reference points around OVA, okay? And work health and safety in general. Practice facilities also speaks a little bit about it, and your business operation systems, which is your risk management side. So they're the three criteria if you want to go and have a little look-see. Now, the RACGP does have a document, and I've given you the hyperlink there. It's 100 pages. It's very technical, but it's actually very good. It's quite specific, right down to sort of identifying, you know, behaviours of concern as well. We're going to cover a lot of that next fortnight, but that's a little link for you if you haven't already seen that, and I'm sure you have. So again, we come to our blue side, looking at these systems. What are the things we've got in place? So, you know, my question to you before was around what are some of the practical systems you already have? These may be informal. You just may have a sort of unwritten rule that, you know, at night, if the car park's if you've got lots of trees, depending on what your physical location looks like, then maybe we've got a rule that, you know, people need to leave in pairs. Yeah, what's the lighting like? You know, lighting can be sort of fixed outside. So these are the things you can generally pick up in your OHS site audits. I'm suspecting that this is where we're probably going to have the biggest opportunity to add value in our support with you over these next 2 sessions, is really in this space. So looking at that internal practice environment and the team responses. Signage alone is not enough. The signage might remind those of us that are just feeling a little bit frustrated, you know, that the good people who are just frustrated, scared, that might keep some of us in check. It's not going to stop your bad people. It's not going to stop your mad people, again, disclaimer around the language. So you do need this sort of holistic response. And there's also the risk that we actually still forget the people, you know. So this is sort of this system. Now, the next is pretty interactive, so we're going to have to get a bit of discussion happening, folks. Firstly, let's have a look at this. You know, the one thing I found intriguing, way back to my work in the divisions network, which is going back like 15 years or something, the thought of having safety screens installed to keep staff safe from OVA, you know, it was such a battle to do anything like that. Until we had some pretty horrendous incidents where actually a GP was killed during a consult in Noble Park. And then we started to see OVA being taken a little bit more seriously in primary care. But it amazes me how many clinics still didn't have any screens and how quickly they've all just come up as a result of COVID. So if we want to do a bit of reframing, positive reframing, I mean, let's celebrate the fact that we've been able to do this, because whilst it again does maybe present some extra challenges communication-wise, it must be giving people a bit more reassurance in terms of their safety, particularly their physical safety. So now, is everybody able to access that quiz? Try again. Can people see the poll online, the poll EB? Just sing out.
Activated again, Tanya. That's it.
Thank you. I was really holding out hope that, good, that some of you had them before COVID, yeah. Just give it a little minute to, it's amazing, isn't it? Yeah, it really, yeah, it fascinates me that, again, because for our physical safety and for known OVA risks, which were known, and if we look at the stats around how many people are impacted by OVA, that, you know, we couldn't get the push to put screens in, for example. I mean, it's one measure, and yet, I mean, a pandemic obviously is pretty serious, but the way this has just happened so quickly has been really interesting. So let's celebrate that. So you do have a system there, right? You've got a safety screen. All right.
Tanya, the thing is, the ones we've got put in are really only sneeze guards. They are Velcroed to the bench. So they're not, yes, they're sort of stable, but they're not a safety screen. They are only a sneeze screen.
Wow. But some are actually quite fixed, hard plastic that have been kind of bolted into the desk.
Yeah, we got ours quite quickly, and that was what we could get quickly. We're part of a bigger practice, a number of practices, and they are rolling out a bit more substantial ones, but still not what I would call security screens. Yeah. They are still mostly for sneeze protection as opposed to safety, you know, full glass or full really heavy duty for violence type thing.
All right, that's interesting. Thank you. And I mean, does anyone else want to comment about, I mean, is that the majority of the case, do you think?
Yeah, that's the case for us, the same as Jocelyn.
Okay, so sneeze guards more than
Yeah,
the heavy plastic.
yeah, but they do feel good. They do make you feel more secure.
Yeah.
But, you know, if someone were to throw something at them, they may fall off the counter. They're not heavy duty.
Okay, so they look pretty secure. Again, I don't know.
But yeah, I mean,
I
yeah.
haven't seen yours, but yeah, I know some of the ones I've seen have looked really heavy duty.
Yeah, and like Jocelyn said, it was a quick solution to the problem we were facing at the time.
Right, there's been lots of quick solutions. So we've been able to adapt very quickly to some things. Yeah, okay. Well, it's a starting point, right? And at least maybe it gives the perception outwardly that, you know, it's a bit
I think it does. Yeah.
Good. But I love the fact you say that, you know, you feel safer, which is really great.
Well, yeah, I think that it just gives that, it may be a false sense of security, but it is a good feeling.
Yeah, and if it provides a bit of reassurance, you know, that's the emotional well-being factor, isn't it, for staff?
Yeah, true. Yeah.
But I've just loved seeing these pop up. I mean, again, I feel sad. I think, how can this not have been done because people were getting, you know, assaulted? That wasn't enough. Now, anyway, I'll stop harping on that. So it's great that we're seeing them.
Sorry,
So the thing,
go on. We did have Carolyn say that they've got theirs for infection control rather than security, but they haven't actually needed for protection from violence.
yeah. Yes, all right. Well, it's a starting point, isn't it? So, I mean, the good news is, the very good news for general practice, as opposed to our acute health system, is that you can actually refuse care unless it's an emergency. So in the acute sector, they're legislated. They cannot refuse care to somebody. There is, you know, a whole process you have to go through in very rare circumstances that you might be able to deny care. But in general practice, you can. And so I've given you the extract there from the standards. So you definitely have the right, and it can be, you know, in the middle of a consult, although you might need a police response to do that if someone's turned really bad, or it can be following up. So it can be after the fact. So this is where I was talking to you about your systems. Do you have something written in your clinics where, you know, if one of our patients is, and this is where it becomes quite subjective too, as to what's aggressive, so this can get tricky. But if you feel the behaviour was inappropriate, was threatening, had an impact on the staff around them or other people, you know, how are you flagging that in their medical record? Are you putting an alert or a warning in, or is there an option? Wouldn't it be nice if in the alerts and warnings you had OBA? Maybe it's there now, I don't know. So it's about what you're doing after that fact to then build this history and to maybe send them a letter after 1, 2, depending on your tolerance level, to say, you know, your behaviour's been inappropriate during the consultations, you know, however you want to word that, 3 strikes you're out, however you want to play it. But there's some options to look at that. If you're not aware of that, have a look at that, because this again is a bit about the post-incident support. When I did a whole range of interviews across Latrobe Regional Hospital, I did a lot of staff interviews around OBA for them. And, you know, obviously they've got their mental health inpatient unit, they've got their emergency department, interesting demographics, all sorts of things at play there. About, you know, one of their sort of frustration, it was, we've got all these signs up that say, you know, we're a zero tolerance, we don't tolerate occupational violence and aggression, but we do nothing. You know, people come in and they're waiting in ED and they're throwing things around and they're abusing us and we can't do anything. We might call the police, we can't do anything. So there's that real sense of, what's the point of having a sign, because no one helps us anyway. You know, it doesn't make any difference. And that's very hard in the acute sector, but for the general practice sector, you can. And so my message is that maybe some of your staff will feel a bit more validated in terms of their emotional well-being. They'll feel the practice really cares about them because they're doing something. You're not just having to put up with that poor behaviour again and again and again. Does that make sense? No one's saying it doesn't, so I'm assuming it does. So, you know, explore that and really, and think about what sort of systems you might be able to design where you're being a bit more proactive in this space and setting that really firm expectation that, well, there's a sign on the wall and we actually follow that up. You know, we actually take note and follow it up. Okay, so this was, you know, where I was just leading. I'm really keen to know if anybody already has that system in place, where you might flag someone who's been aggressive previously, and you know how you flag them. Is there somewhere in your medical software now that does enable you to? Is there an OVA alert in any of the software now? Practisoft, Medical Director, whatever we're using across the region. Michelle, I'm going to put you on the spot. Yeah, so I'm really interested to hear from the field about what you might have in place. So firstly, let's just start. Does anybody have this system in place where they do flag people who have been aggressive?
Yes.
Yes, we do.
Fab. I'm so excited to hear that. That's great. Well done. All right. So how do you flag them? Would someone like to share? Because this is an opportunity for others to learn, okay? Because this is new for many people. It's really important people understand you do have some opportunities to, you know, cut some of those patients, repeat patients that are problematic. So let's share the system that you have for others. It's going to be great. Who'd like to share?
We, on our patient details, just have it flagged that they're a violent or an aggressive patient. So when they go to make up an appointment, it will pop up. And it's also in the medical side, in the doctor's notes, in the warnings that they're an aggressive or violent patient. And we have had the support of GPs sending out letters refusing to see patients who have been aggressive towards reception staff, or advising them that they're not with our registrars. We have quite a few registrars that they're flagged as not to see registrars because of the way they try and manipulate the younger generation. Yeah, so we've got a few of those processes in place to help out.
That's great, Ruth. And do you have a sense of how, you know, your reception staff and how the clinical staff who have to deal with them as well, how they feel about the fact that that's followed up? Do you think it gives them that, I don't know, a sense of care or a sense of reassurance that there's that system?
I think it does. We had an incident a couple of years ago where we probably didn't have these particular guidelines in place, and this made us rethink how we dealt with patients who were aggressive, not only to the GPs but to the reception staff. So we all had a meeting and came up with how it would work, and it wasn't just the admin side. We all sat down, clinical and admin, and worked out a process, and I think that helped because it got the receptionist point of view how they felt, and yeah, it works out quite well. You know, and if the reception staff feel threatened, they just have to pass it on to me as their supervisor, and I'll deal with it. I don't expect them to take any abuse at the front desk, and I will step in if I hear it. So yeah.
Fabulous. I really love the sort of co-design that you've all sat together, and because it's a whole practice problem, isn't it? It's not, you know, it's not just one area. And I love that you've sort of done that collectively, because one, it communicates the system, but two, it's sort of everyone's in it together. You know, we've seen this messaging, we're all in it together. I love that. Thank you for sharing. What a great example. That's really good. So there's lots of opportunity to add value to your current processes if you're not doing something like this. And I'm sure, putting Ruth on the spot, I'm sure she'd be happy to share more about how she's gone about that. You know, some of the other things, just simple things, is around if you know you've got that problem person coming back, you know, how do you prepare for the arrival of that person? Are you doubling up? You know, do you as the practice manager, for instance, are you just being present on the front desk around that appointment time slot just to add some moral support, or you know, is it the same person that's on all the time that's copying it? Can you kind of change things up a bit? So it's just thinking about things a little bit strategically. It's being a bit person-centered in terms of the staff. So how can I mitigate the impact of this on these staff members? Now, you're also a staff member, right? So it's about mitigating the impact on you as well. But just thinking about is there ways I could do this a bit differently to support. So we're just taking a bit more of a conscious, proactive approach. And the other thing is around, you know, obviously for newer patients, having a note and a clause that they sign on your patient registration forms about behavioural expectations, and with a statement that says that, you know, basically we can evict you from the clinic if you misbehave. Again, you know, this may help influence the behaviour of our group, our stressed and worried group. Going to have very little impact on our bad people. They're going to do whatever they want regardless. But, you know, we know that most of our group are that worried group, right? All right. I'm really keen to understand, we're coming to the end, folks, but I'm really keen to understand if anyone has sort of a written system, so an actual guideline for how they respond to actual OVA events. So, you know, one, has anyone, any of these questions, so has anyone actually done a formal risk assessment using the hierarchy of controls and designed some controls around incidents? Does anyone have a team response determined? So if this is happening at the front desk, you know, senior receptionist comes in or practice manager comes in, or if this is happening in the nurses, this is what happens. Does anybody have a sort of defined response where team members have different roles? Okay, so there's lots of opportunities then to, you know, again, to add some value by considering what this might look like. And Alex will talk a lot about this on the 8th at the next session. So she'll talk very much about the role of everyone in, you know, when something's playing out, and how not to escalate things further, but how to just give reassurance and support to the individuals that are feeling the brunt of it. I mean, I've been involved in incidents where I sort of attended the front desk to support a staff member, and, you know, the others on the front desk, they're just really happy it's not happening to them. They're really happy they're not having to deal with this annoying patient, and, you know, everybody's kind of pretty distracted. No one will make eye contact with you. So, you know, how is that feeling for that individual who's just sort of bearing the brunt of it? So there's some great things we can put in place that, again, just help that wellbeing side for your staff, you know, at the minimum, but then to look at, you know, really sort of proactive management of these episodes. And I think there's the risk that we do just become so used to it becoming, you know, a regular thing that we forget that actually we can design a bit of a system around it, you know. Okay. Now, does anyone want to have any further or make any further comments or ask any questions just about these sort of systems that we've just touched on before I continue? Okay. I'm mindful of time. I'm doing all right for time. So next week, no, don't run off because I've got a couple more slides, and then Belinda's going to come back on too. But next week we're going to look at this sort of system side more, like I mentioned. So this is what we're going to cover, 2 weeks time. This is what we're going to cover. And I'll also have a Word template for you, which will just act as kind of your system template. Like I said at the start, you know, it may add value for those that have already got a system in place. For those that don't, it's a starting point for you. So they're the things that we'll look at. And just to summarise what we've covered today, because it's a lot of information, in summary, but OVA is very complex, and it requires this holistic approach where we're looking at both the systems and the people. And our people are internal and external, both play a part in our OVA episodes. There are many external and internal or intrinsic factors that contribute to OVA events. As I said, the internal and external both play a part. Environmental factors are also at play there, and I'm sure you're all tuned into those things as well. Even minor verbal arguing, aggression, just being generally difficult and painful, pushing their luck, can impact staff emotional wellbeing. So, you know, please really be mindful of that. I'm going to talk a lot more about workplace wellbeing, emotional wellbeing next fortnight. A big part of our work at Wambara is around that's creating mentally healthy workplaces. That we do need this sort of systems approach, okay, to prevent, intervene early, and manage actual episodes taking place. And we're going to give you lots of practical tips for that. And again, just reinforcing that systems plus a culture of care equals workplace wellbeing. So looking at your culture of care. Again, I'll give you more information on that next week. Okay, in 2 weeks' time, sorry, on the 8th of September, this is what we're going to look at. Watchful waiting and de-escalation, the wonderful Alex, who is a psych nurse at a very busy Melbourne mental health inpatient unit, deals with an awful lot of very interesting cases, and she'll give us her fabulous insights. And I've seen in her presentation some really great tips, actually. I was like, wow, this is great. Looking at a team response, managing OBA, so a couple of little quick things that you can do just to really make people feel much more supported if they're dealing with those sort of difficult people. We're going to explore the wellbeing, so the impact of trauma and vicarious trauma. Explore what does it actually mean to build a mentally healthy workplace? What does it look like? How do you do it? I'll give you your resources, and I'm going to just give you, you'll have the option to access at a small fee a whole heap of wellbeing, excuse me, resources that can help you build your sort of mentally healthy workplace. It's a bit separate to this presentation, but I'll just show you that as well because it might be helpful. Okay, so that's me. I've spoken at you for the last hour and a bit. I would very much like to open up for any further questions or comments. My contact details are there. You can follow Wombara on social media. We're quite often posting helpful bits around team effectiveness, around workplace wellbeing, and you can also follow me on LinkedIn for the same sort of useful content. But any questions or comments or thoughts or things you'd like to see built into the next session that would be really helpful for you? Anybody? It's always nice to know people are still there. So if someone just wants to have a holler, that would be great. Everybody still there?
Thanks, Tanya. We're still here.
Thank you.
Put your videos on as well.
See some hand raisers. People are still here.
Can I ask what's the password for the next session, please?
So what was that?
The
Susie,
password.
I'll email it to you.
Thank you.
No problem. Thanks, Tanya. That was a really great session. Really appreciate it.
Thank you. I'm glad it added some value to you. That's the whole intent, isn't it? It's a tricky space, but there are things we can control, which is nice because we like to control things. It's not just me, surely.
Definitely some beneficial information in there. I'm sure a lot of practices will go away and reassess what they're doing and the issues that they face. And we certainly know that some practices have mentioned that they have not had issues with violence or acts of aggression, which is fantastic. But it certainly helps to make, certainly helps to have a look at what processes you have in place just to mitigate those risks should they happen.
Yeah, and it's fabulous if there's no issues. That's just dream time. And it would be, I'd say that would be the exception.
As I said earlier, we have zero tolerance. So when the new patient comes, we already tell them about that. So there's no second chance. So there's no need to flag down who's violent and who's not because they don't have a second chance. Zero tolerance means no one chance only. So no repeat violence patient.
Do you find that it's well received from the patients that attend?
Yes, we tell them from the beginning when they sign in as a new patient. We will tell them that already and got signed right in front of our reception. As they face the reception, they're seeing zero violence AMA form, AMA postal that we put out. So there's no flagging of second chance that violent patient to flag it because we don't give them a second chance. We say you're not welcome in this clinic.
So do you have a sort of staff follow-up for when, if it does occur, for the ones that you give one chance to and then they're out? I mean, is there a system that you follow up?
No, we tell the patient already because point to the sign, zero tolerance, AMA poster, because we have been violent, we do not want you as a patient anymore. So please find another doctor. You got a month to find another doctor. If it's urgent, we will still see you within 1 month. and then you got to find a doctor to take over your care. But new patient only got one chance.
Does this include patients with verbal aggression, or is this just physical aggression?
All aggression.
All aggression. Okay.
Zero tolerance.
There's a lot of acute services that would love to be able to do that.
That's what I was thinking.
You have to be firm, otherwise they do not believe what you say.
Yeah.
They can swear you.
Yeah.
You got to say
I
what
mean-
you mean, what you say. Got to mean what you say and say what you mean.
That's a good point, being very clear in
Yeah, no half measures. So there's no bargaining.
Is there ever any confusion about interpretation of aggressive behaviour if it's just verbal, whether it's received, maybe the receptionist is perceiving it as aggressive and it's maybe just a bit of frustration about wait time? What's the tolerance there?
No, because we're very punctual here. We have 15 minutes per patient, or they can make a long appointment. So we give them enough time and we don't tell them to be punctual, not to be late. If you're late, you'll miss your appointment. Then you have to wait to the next vacancy.
We find on the odd occasion that people do become aggressive. They don't even realise they're becoming aggressive. They're just frustrated.
We have to empathize with them and find out why and explain to them. I say, we know how you feel and why you feel this way, but certain things are unavoidable as an emergency. If there's an emergency, we have to attend to the emergency first. So the routine will be a bit late. Then we ring to cancel the other patient or tell them to come a bit later.
And then reception to reduce the risk
Thank you.
of that aggression.
Anyone else have any questions of me before we run away? Grab me while you can. Tracy, I can see you speaking, but you're on mute. I don't know if you're speaking to us. Okay. Well, we will see you again in 2 weeks' time. Belinda, you've still got some. Were you going to do something more, or?
Yeah, just if anyone's wanting to hang around to have a little bit of networking, if you want to have a chat amongst yourselves. I understand it's a very busy time in general practice at the moment, but please feel free to put your videos on and have a chat to each other. And thank you, Tracy. Thank you, Tanya. Not Tracy. Thank you, Tanya.
I always get Tracy. It must look like a Tracy.
Oh, it's my blonde head at the moment. Thank you very much for the presentation today, and I will certainly be in attendance next fortnight with you. If anyone has not registered already and you do wish to register, the registration details are on our website. Please get in contact with us if you have trouble finding them. But otherwise, we will send out the information as well from today's session, along with those survey responses as well. And so you can access all your certificate of attendance. But thank you, Tanya, and thank you, Alex, as well. We'll look forward to seeing you in a fortnight.
You'll hear lots from Alex next week. Yeah, fortnight. Bye, everyone.
Thanks. Bye.
Bye. Bye.